Welcome, everyone. As you're aware, research on ALS is continuously progressing. At Everything ALS, we are dedicated to uncovering new discoveries, aiding in early detection, and working towards finding a cure for ALS. You can assist us by participating in our speech study. The purpose of the speech study is to enhance the diagnosis and prognosis of ALS. We are seeking participants to provide 5 speech recordings, each lasting 15 minutes once a month over 5 months. Pretty easy to complete. We welcome healthy participants as well as individuals diagnosed or probable with ALS to join us. To enroll, please visit everythingals.org/speech project and fill out our form. Thank you, and you will find the email address posted in the chat. So welcome. And right now, I will turn this over to Indu Navar, the founder and CEO of Everything ALS. Welcome, Indu.
Hello, everybody. It's so great to see you guys today, and we have an exciting event, and I will have Christian take over the stage today, and he'll introduce the speaker and also moderate along with Martha. So, Christian, it's all yours.
Great. Thank you so much. Hi, everybody. Yes, it's a pleasure to be here. We're really excited to have tonight's expert talk series. Reminder, of course, it is a live interactive program when you can join us here live. So your questions will be welcomed, and we'll do our best to answer every question. And it'll be available in just a couple days afterwards for YouTube if you want to share it with additional friends and family. Tonight's speaker is Dr. Eufrosina Young. Dr. Young is the director of the ALS Clinic and clinical neurologist at the Upstate Medical University. Dr. Young is a board-certified neurologist who completed her neurology residency at North Shore University Hospital, where she served as the chief resident. She is fellowship trained in clinical neurophysiology from the State University of New York at Buffalo. And Dr. Young served as neurology medical director for the Community Memorial Hospital in Hamilton, New York for 5 years before joining Upstate Medical University. Since 2014, Dr. Young has been the medical director of the ALS Clinic at Upstate Neurological Institute in Syracuse, New York. She's been the medical director for intraoperative monitoring since 2015, and it's a pleasure to have her here tonight. And Dr. Young, the floor is yours. I think we're going to learn a lot from you tonight. And as I mentioned before, any and all questions, use the chat if you need. If you want to ask a question, we will take a log of them. So after her presentation, we'll get into the Q&A. And with that, I'll pass you the mic, Dr. Young.
Thank you so much, Christian. And I'm very excited to be here this evening. I feel like you've opened the door to your homes. I think all my concerns about, what's going to happen this evening. I'm fresh from clinic. There's a lot going on, and yet you all are here. There's a lot going on in your lives, but you set this time to get together and listen to this talk. So I'd like to thank you for that. So this evening, I'm going to discuss digital health technology from a patient perspective. I think it's very important to address this because we hear about digital phenotyping, we hear about voice analysis and contributing data. We hear about remote monitoring, and yet we see it from the perspective maybe of a software developer, of a researcher, of a data scientist. But I believe something that is truly important in developing remote respiratory monitoring is to look at it from the point of view of a patient, maybe a caregiver, and a clinic setting that actually introduced remote respiratory monitoring at the height of the pandemic. Now it's 4 or 5 years after the pandemic. Nobody wants to talk about the pandemic anymore, but I need to mention the pandemic because that's when we realized that the world is a universe, as alluded to earlier by McFinn. I think that we realized soon enough that we had to go beyond our, let's say, comfort zone, right? like literally cross the bridge and find out what are other practices doing, what are other pulmonary disorders, how are they being treated other than ALS, and maybe lessons learned from pulmonary disease can be applied in ALS. So before I begin, I'd like to share with you my disclosures. We do have a research grant from Mitsubishi Tanabe Pharma America, and we do have clinic grants from the Upstate Foundation, Tim Green Fund, and the ALS Association. So everyone in the audience, I'd like you to take a moment to fill your lungs completely, right? Maximal volume, okay? So I want maximal volume, and that amount of air that you can exhale with your lungs completely full, you slowly blow it out gently and empty your lungs as possible, okay? So honesty is the best policy. I'd like you to do it now all together. So it seems easy, but maybe for the audience that are patients with ALS, it's not as easy. And if you can imagine someone with asthma, COPD, interstitial lung disease, or even cystic fibrosis, that whole entire experience would be different from an ALS patient. So how do we measure slow vital capacity? Well, we need a reference equation because we're not all built similarly. So there's anthropometric measures that we have to consider. First is age. Of course, as we get older, our vital capacity is less. Gender, women's vital capacity is less because the lung volume is less. Ethnicity, it also varies. If you're Caucasian, Black, Northeast Asian, Southeast Asian. So these things, vary. And so we don't measure vital capacity based on liters or volume. We measure it as a percentage of predicted value. So, data is one thing. You look at data on the left side and we think, okay, if it's in the lower limit of normal, then it's abnormal. Then we probably have to, let's say, rethink our treatment plan, modify our treatment plan. However, there's certain things that we look for when we measure vital capacity. Now, our respiratory therapists, they live and die by vital capacity. That's what they do. And yet, if you switch them to doing vital capacity from clinic and have them do vital capacity remotely with a patient at home and do it on their smartphones, then it's a totally different, scenario altogether. So as you know, technology can always fail. Before starting this, we already realized that my background was reversed. And this was, I think the lesson learned throughout the last 4 years of implementing digital health technology, implementing remote respiratory monitoring in an ALS multidisciplinary clinic, is that technology can fail at any time, even with practice, even with many, preparation, a lot of work going on in the background. But one thing is certain, a very specific factor other than weight, very specific factor that will affect spirometry and the value of vital capacity that is obtained is the patient's position. So I guess most of us are seated right now, we're not standing. And I remember a couple of years ago when we first started performing remote respiratory monitoring, the patient says, listen, Dr. Young, I know you want me to give it my best. I want to empty my lungs and slowly, maximal volume, exhale all that air. But I can do it better if I'm standing up. And so I wasn't prepared for that. I said, listen, we always do it seated and supine. I've never had a patient do it standing up, but then I learned to listen more closely to patients' comments, caregivers' comments, because really the entire study that has happened, over the last 3 years, a lot of it has been improving a methodology based on patients' comments, patient experience, that feedback that we're getting from caregivers. So a CT scan was done, patient in supine position, standing position, and seated position. And as you can see, they demonstrated that in the supine position, the lung volumes are really much smaller than they are in the seated position. And compared to the standing position, inspiration and expiration in the standing position, you have the greatest lung volumes. So this specific approach of testing vital capacity in the seated and supine position is really key, because more often than not, majority of clinics, ALS clinics, can perform pulmonary function testing at clinic. They have a respiratory therapist, but these tests are done in the seated position for the very reason that there are some patients who just cannot transfer to the gurney. You know, some of our patients are wheelchair bound. We still test their vital capacity, but we cannot test in the supine position at clinic. So here we are talking about remote respiratory monitoring. We're testing patients from home, and that allows for us to actually test more often successfully in the supine position than we would be able to in the clinic. So when we were debating over how should we approach our patient population, very specifically ALS, ALS is not pulmonary fibrosis, it's not interstitial lung disease, it's not cystic fibrosis, it's not COPD. So I'm showing you a graph on the left side of the screen, wherein pulmonologists, see a whole gamut of different patients with pulmonary disorders, and how do they respond to home-based spirometry. So majority of these studies have been done in pulmonary disorders, not ALS. What happened when you increase the frequency of testing going from weekly to daily is your graph from left to right. So adherence, which is the ability of participants to perform these testing as you prescribe them to perform them, decreases over time, anywhere from, let's say, 95% to 55%, just by increasing that frequency from weekly to daily. So why is this important? Why are we talking about vital capacity? So we know that based on the vital capacity, we can prognosticate. And it's not just prognosticating disease progression, it's prognosticating survival. So majority of our patients die within 2 to 4 years of symptom onset, right? And the cause of death is respiratory failure. There's the death of motor neurons that are supplying innervation to the diaphragm and the chest wall muscles. So we must speak about vital capacity because that's our metric. That's how we determine patient outcomes. And I'm sharing with you the data from 2018. Dr. Andrews and Dr. Jeremy Scheffner wrote this article, and it tells us that vital capacity declines per month at a slope of 2.7%, more or less. So that is the slope of decline, 2.7%. And this data is based on hundreds of patients, right? So there's 3 trials, Empower, Benefit, and the PROACT database, wherein they looked at more than 800 placebo participants in those trials that they looked at, and found that on average, the patients declined by 2.5 to 2.7% per month in terms of their vital capacity. And this is not a stratified database. This is all patients, all patients that are participating in a clinical trial. And you might say, well, these conclusions are very specific to the participants, the people that participate in the clinical trial, in the same manner that our conclusions are very specific to our small university hospital setting. And our trial was done engaging 2 university hospitals, one in North Carolina, Atrium Health, and ourselves in Syracuse, New York. But I'd like you to remember this slope, okay? Because this slope will have implications in our small trial. So here you can see what our participants are engaged to do. On the right side of the screen, even with paralysis, the mirror spirometer, which is what we used, can be attached to a table, and the patient able to can seal his lips around that mouthpiece. And you see that smartphone, the personal smartphone is right there, and the patient can see the flow volume loop that he generates as he breathes out of the spirometer, as he does the exhalation and inhalation. So on the left side of the screen, you see that flow volume loop. And before he does all this, of course, we need to get consent. And before that happens, he needs to download the app on the smartphone. So more often than not, our patients come in to our clinic, want to participate in the trial, and have their caregivers next to them, to allow for them to download the app. Everybody downloads apps these days. It seems very elementary, but a lot of our patients need help downloading apps. And a lot of our patients, need to be able to understand, in a manner that they can actually consent to sharing their data, because this is still private patient health information that's going on a database. So we find that the consenting is very important. Patients have to understand that their information is on a database. However, when it comes to analysis and statistical analysis, these are not their names that are showing up, but they're converted to numbers. But nevertheless, this is still patient data that we must protect. And in the left bottom half of the screen, you can see how we are basing our quality, acceptability, and reproducibility, and making use of the Global Lung Index as a reference equation, and making use of a grading scale wherein we can determine if the quality is at par with a grade of A or a grade of E. And this is important because the American Thoracic Society and the European Respiratory Society 2019 guidelines gives us the criteria for what you would conclude as an acceptable vital capacity recording, what we would conclude as a usable vital capacity recording. And these grades in the lower half of the screen would tell us that if you're comparing one study with another, more or less you have to know that they're equal in terms of the number of vital capacity measurements of similar grade. But let's say from grades A to E, majority of the vital capacity measurements fall between A and B. So those studies are comparable. So we need this to anchor, our data. Okay. So on the right side of the screen, just shows you that, with loss of dexterity in hands or loss of sealing ability because of weakness in the lips, there is that aspect of monitoring vital capacity that can diminish over time, for which the caregiver truly has increasing importance in ensuring that our patients are able to monitor over the course of time. So we're ready to deploy. Cystic Fibrosis Foundation, at the height of the pandemic, just a quick phone call. Hey, from Syracuse, New York, we'd like to know what you guys are up to. And the response I got was, well, we've shipped 13,000 of these portable spirometers, and we're going to use a data dashboard and so forth. So I said, well, then how do we do that? Right? How does one get initiated and taught how to start remote monitoring when there's chaos all over and we don't really know, like, how are we going to learn this method? And true enough, it was really a phone call. I hate to make it more dramatic than that. It was really a phone call, and finding out that the software developer, we live in Syracuse, New York, was in Albany, New York. So they're not too far, and they were very easy to talk to. And we said, we want to do this. We want to implement this remote respiratory monitoring in our clinic. We did know, based on prior studies and pulmonary studies, that we must use our gold standard, which is the VIASYS system, and that is the conventional spirometer that we use every 3 months when we see our patients in clinic. However, the world is different. The universe is different. Now we have to switch to telemedicine, and we have to figure out a way of monitoring our patients from home to ensure that their disease, is either held at bay, or if it was declining, we would be aware of it and we would know how to modify the treatment plan. So we engaged our patients to test at clinic. So we did their clinic conventional spirometry, seated and supine, on the right side of the screen, our gold standard. And the same day, or within 7 days of that testing, we engaged our patients to use the portable spirometer and also, again, test in the seated and supine position so that we could compare. We want to make sure that our data is anchored onto the gold standard. And then we were ready to ship the patients home with the portable spirometers. Our intent is to be able to follow our patients from home every 2 weeks. It was also our hope that our patients would still return to clinic every 3 months. So within a period of 6 months, we would have a baseline test, a test at 3 months, and a test at 6 months. But in between, we would allow them to engage with our respiratory therapist and test from home. And clinicians, the team, would be able to access that data and then make treatment changes based on the information obtained. But of course, it's never easy. I mean, the illustration is one that tells many stories, and also the illustration simplifies a process that appears simple, but there's a lot of this work that goes on in the background, and it's amazing that the whole program got put together. Because at any point in time, something can go wrong, and it will go wrong. So first lesson we learned, and right off the bat, when we started the journey, from 4 years ago, we knew that digital health technology is a tool, but that's not the end of the story. The data collection will allow for us to extend our care for our patients. The data collection was not the end goal of our endeavor. We just really wanted to know, how do we take care of our patients better? So there is a software application that is downloaded on the cell phone, and we're able to access a clinical dashboard, a clinician dashboard, as you can see, and this data dashboard is accessible to clinicians. But on the left side of the screen, as you can see, patients can also see the results on their smartphone. And so you would think that, well, most patients would like to know. Well, actually, no, some patients don't want to know, particularly if their vital capacity is not stable. If they're seeing a decline, it can trigger, all sorts of thoughts, sometimes trigger anxiety, sometimes maybe it leads to this change of heart. That in the beginning I wanted to participate in the trial because I thought I would be contributing to the good of the management in ALS. But then now I'm rethinking it, and I'm developing this anxiety that it actually caused some of our participants to withdraw. But there were only a handful of people that withdrew, and I have to say that I believe it is from the continued interaction of a respiratory therapist, a human being, not an animated representation of a human being or an avatar, but an actual human being that interacted with a patient on the cell phone, on telehealth, that allowed for our patients to make that self-determination that, hey, they're not just collecting my data, they're actually using the data they collect in order to let me know where I'm at with my disease and what changes I need to make in order to remain stable, in order to improve or decrease the risk of developing an infection in my mouth, in my throat, in my lungs. So there is that. We were not giving people drugs. This is not a drug trial. Majority of trials that are more observational, very difficult to engage patients to adhere, throughout the duration of the trial. But I have to say that the role of the respiratory therapist here, the supervision, of a human in conducting this trial, made a whole world of a difference. So then we do have patients that disengage, as I said, because it increased anxiety. And one thing that I have to say, to add to this, is that what increases the anxiety of the clinician is when all these information are disconnected. So there is that effort to connect the data from the data dashboard with electronic medical record. And going to the right side of the screen, that helps the whole team engage, as opposed to, logging on to a different username, password, and getting on to another screen in order to get this information and put it together. Any effort to integrate with electronic medical record, or EMR, is really very helpful, because data is only data when you access it, and access it quickly. And what we learned over this time frame is that some of this data is really actionable, and some of this data is allowing for us to improve the care. So lessons learned: it's a collaboration between neurologists, pulmonologists, respiratory therapists, nurses, clinic coordinator. It's a team effort, and it's listening in on what patients and caregivers have to say, because they're the ones performing these repeat measurements. On their end, it may be 10 minutes. On the end of the clinic, it may be hours. But then there are situations wherein, we think, oh, the internet failed, and therefore the patient tried to use the spirometer and then was unsuccessful. But then there are other glitches, and these glitches you realize as you go along, because you're actually, in a sense, vetting the whole entire system in your clinic into the hands of ALS patients and caregivers, and making a determination that, yes, this is very helpful, for you, for the clinic, and maybe in the future for research. So the clinical staff and the caregivers are aware that at-home telespirometry, or AHT we called it, influences changes in the treatment plan, and we improve as we go along, and allow for the best outcomes. So this is our study. So it went from 2021 to 2024, and currently we're doing analysis. And this is just showing, part of the analysis has been shown in a poster at the American Academy of Neurology. So we want to make sure that the data we're collecting are, number one, they're of high quality, and number two, that the data we're collecting is anchored onto the data that we obtain with conventional spirometry. So what's portable spirometry and what's conventional spirometry? Are they giving us the same results? And what we're seeing here in this analysis is that the results are really very similar. However, the limits of agreement may be wide enough for us to say that you cannot just feel comfortable about shipping these spirometers to patients' homes and never seeing these patients, at clinic, and feeling comfortable that the data that you're obtaining are truly high quality, reliable, repeatable, and acceptable. So we still see our patients at clinic, because we need to make that connection. And what we did over a 6-month period of time is to test every 2 weeks. And at the onset, when the patients enroll and we obtain their baseline vital capacity using our gold standard conventional spirometer, we figure out a way of analyzing where they're at in terms of progression, and where we could be at in terms of using these measures, outcome measures, to prognosticate outcome. Now, in the bottom half of the screen, you can see we're doing it in the seated and supine position, slow vital capacity, and we're breaking down, the vital capacity less than 60% red, which is our lowest tertile, so maybe lowest performers, 60 to 80% in green, the middle tertile, and greater than 80% in teal, the upper tertile, the high performers. And it's important to be able to order the data this way in order to stratify, have a strategy wherein we're stratifying our patient population so that we can determine where people are at and how they progress over time. Do some patients stay stable? Do they plateau? Do they decline over time? Is it an up and down? We all assume it's a downward spiral, but some patients are up and then they go down. Some patients are down and they go up. And it gives us, insight. And this is what I learned personally from, our respiratory therapist, a respiratory coordinator, that the manner by which these vital capacity measurements are obtained is very important. We need to be able to ensure the quality by making sure that our therapists are trained even if they're experts, but they're trained to obtain this test remotely. And we need to ensure that we have a proper seal, that the technology is working. If there's any updates in the firmware, in the hardware, in the software, these all three are talking. And so there's a lot of this, that we learn over time. And I think that if you recall earlier, Dr. Jinsey Andrews' graph, wherein the conclusion was about 2.5% drop slope per month over time was average among 800 or so patients that were participants in the trials, including PROACT, and in the placebo group. Where we're seeing is that if you break down our participants, 98 participants, into tertiles based on their baseline conventional spirometry, again, the three tertiles, less than 60%, 60 to 80%, and greater than 80% slow vital capacity, that 2.5% is actually looking more and more like our group in the less than 60%. So we'd like to be able to use this approach in order to make a determination that patients may belong to one tertile. However, there may be ways of improving outcomes, right? This, based on Dr. Andrews' research, is that if you look at that 2.5% rate of monthly decline in all the databases, and if you slow the decline of vital capacity by 1.5% per month, you're actually reducing the risk of respiratory failure by 20%. So lessons learned. First, we learned from the pulmonary doctors, pulmonary disorders. This is the approach they had using digital health technology and remote monitoring. And it's acknowledging that ALS patients are not COPD. ALS patients are not cystic fibrosis. There are similarities, but there's also major differences that we must consider in order to allow for our clinical trials, our clinics to be designed around ALS patients. So this illustration, had many alterations. I think that everyone had an input on how it should look like, where the arrows should be, which one should go first. But I think we start with the technology. The technology is available. It's been available for, I believe, more than a decade. I look back at an article dated 2018, and there were already 18 of these portable spirometers. Of course, some of them were FDA approved, others were not. But as you can see, it's an exploding area. And so we start with the logistics. What do we have to deal with? How are we accessing the data? Who is going to access the data? And then we go on to our patient population. We need human supervision, and our respiratory therapists, our respiratory coordinators, they are key. They also have a learning curve in terms of implementing remote monitoring, but their wealth of information, and I personally learned a lot from them. And then we have the clinic. This is not just the neurologist or just the pulmonologist or just the respiratory therapist. This is a whole project in and of itself, wherein all the members of the clinic are aware that we have a focus. We're focused on respiratory care, and we engage our patients, to improve their care by making sure that they're performing airway clearance techniques. We revise treatment with cough management, secretion management, and we aggressively early on introduced non-invasive ventilation, because again, looking at that curve, we know that it's a race against time. Our patients do not have the time to wait for medical insurance and Medicare to approve their non-invasive ventilators. So I think when I prepared for this talk, I looked at all the information out there, and these three articles are must reads for anyone interested in pulmonary function testing, looking at non-invasive ventilation and the effect on survival outcomes. So lastly, this is our little village. I'd like to thank everyone Special thanks to Dr. Anuradha Dilip, our medical director, Dr. Benjamin Ricks Brooks, who really mentored, the whole trial and venture into digital health technology implementation in an ALS multidisciplinary clinic. And I'd like to, thank all our patients, their families, the caregivers, and I'd like to thank our ALS coordinator, Stephanie Lesson, who really, provided all the positive influence, on the entire clinic to embark on this journey. Thank you.
Thank you so much, Dr. Young. Thanks for that great presentation.
Okay, folks, we're going to press that button and say, see you soon. Look in the mirror, smile. That's right. And make those hopes come alive.
Have a great night.
All right. Thank you.
Thank you.
All right. Okay. There goes that button, I think.
Yeah.
One of the hardest things I do.